Vardhaman, please.
Yes, thank you so much. And I think in the interest of time, I'm going to keep it short. If I can have my slides on, please. Yeah, perfect. So friends, we all know that post-LASIK or smile epithelial ingrowth is a rather uncommon complication. It is characterized by ingrowth of the corneal epithelial cells, which are stratified epithelium at the interface between the flap and the stroma in LASIK and between the cap and the stroma in smile. This was a beautiful classification given by Probst and Machat many decades ago, which actually discussed about how the epithelial ingrowth should be tackled as you are actually going, let's say, progressively more in gradient. Vast majority of this epithelial ingrowth, fortunately, are innocuous and they're non-progressives. They need only observation. Many of them would actually disappear with resolution. But we are more worried about those progressive grade 2 or grade 3 epithelial ingrowths which have thicker cells, discrete cells with epithelial nests, and there is no demarcation line. You can also see that there is a kind of slight rolled up edge at the edge of the flap, and many of them are known to have epithelial fistula. These are the ones which require intervention, mainly in the form of debridement, which has to occur on the surface of the stroma and also under the surface of the flap as well. You have to be sure that you are not damaging the surrounding epithelium, and of course you can use any adjuvant agent such as absolute alcohol or mitomycin C if it is required. And of course at the end of the story you have to put the flap back in its position and basically put a BCL if you want. Many of these epithelial ingrowths also are known to recur, and if there is a recurrence after the first intervention, there can be additional tools to your armamentarium, such as using antimetabolites such as mitomycin C. You can also secure the flap to the stromal bed using a 10-0 nylon or a fibrin balloon, especially if you have epithelial fistula that you can locate. If it is a very discrete and peripheral epithelial ingrowth, you can use Nd:YAG laser at a very low energy setting, and many of these entities have to be doubled up with a very fine 10 micron PTK to smoothen the surface. Fortunately for us, the aggressive ingrowths which go into the stage 4 are extremely rare. This is one of these cases which had presented to us about a decade back. This was a patient who had undergone LASIK enhancement 2 times in the peripheral centers elsewhere, and the patient had, after the first enhancement, second enhancement actually had epithelial ingrowth. This was a hyperopic patient who underwent, and that time you can see that there was a very high irregular stigmatism which had actually gotten induced because of the same. This patient, of course, we could not, there was no way that we could do a flap lift and epithelial ingrowth removal because there was a flap melt in place, and we had to debride this epithelial, flap. And as you can see, this was a paper that we published about a decade back in which a flap amputation along with PTK and the mitomycin C demonstrated a great outcome in this extremely severe case. This is another case that was referred to us about 4 years back, and you can see there is a huge amount of epithelial ingrowth. The patient had already received 3 times epithelial ingrowth treatment in the form of flap lift and scraping using mitomycin C, so on and so forth. There was already a lot of thinning over the epithelial ingrowth on the flap, and there was a flap melt in place. So again, in this case, we had to go back and of course excise this flap, do a flap amputation, do a bit of mitomycin C and a very narrow amount of PTK of 10 micron, and you can see from the preoperative 3 meters the patient actually improved to 6/9 outcomes by this approach. So this is the way the epithelial ingrowth is generally tackled. Fortunately, most of them are extremely innocuous and we don't have to deal with them. However, compared to LASIK, the epithelial ingrowth in smile is even rarer because we have a very small cut. In fact, these are 2 large series of smile, as you can see, one by Sukandar et al., the other one is by Versen et al., both of them in thousands, and in none of them they actually had any case of progressive epithelial ingrowth. In fact, there are only 2 cases which have been reported of progressive epithelial ingrowth post-smile, one of them from India, from NN, the other one from France. But in both of them, they actually tried to go from the small incision to debride the epithelial ingrowth, and there was a recurrence 2 or 3 times and had to be used in the form of glue. So this was an interesting case. This was a patient who was referred to us. She had undergone smile about 3 months ago. In one eye, she was doing extremely well, but when she presented to us, she had a poor visual acuity of 6/36 with a very high amount of mixed astigmatism. When we saw the patient on slit clamp, we could see there was a very discrete isolated epithelial cell nests in the visual axis. You can see it in the OCD as well, and this has resulted in a high amount of mixed astigmatism in this patient having a very poor visual quality and quantity. When we did the fluorescein stain, we could see that the incision of the small incision that we take in smile was actually quite intact, and it was devoid of any epithelial fistula. So this was extremely important for us to know how to approach this case. So as we discussed, there were two cases which are already published. In both of them, they had gone through small incision, and in both of them, there were a high amount of recurrences. There is one patient which is published already with yak laser, but that was in the periphery. So as Thomas Edison says, there is a way to do it, and we have to find it. So in this case, we actually used in a novel way the circle software, which is used typically as enhancement modality for smile, which allows the conversion of smile cap into a flap by those extra additional femtosecond laser pulses which come in a donut fashion. This is how the circle software works, and as you can see, there is something called a junctional cut which goes 10 or 20 micron above and below this junction of the side cut of the new circle donut versus the initial lamellar cut, and you can open up the same lamellar flap. So as you can see, this is a circle software that I'm using. This is how we have got an entry into the interface of this post-smile epithelial ingrowth. One of the most important things that you want in epithelial ingrowths is to have the full access so that you can debride the epithelial ingrowth completely, and the way that you can have access is by basically creating a flap with the help of circle in which you can now open up the entire lamella cut, and now you have full access to the epithelial ingrowth. You can use any kind of spatula to debride the epithelial ingrowth, epithelial cell nest from over the surface of the stroma and under the surface of the flap as well. Once this is done, then of course you can use any tool of your choice like mitomycin C, put the flap back in its place, and after this novel use of circle, we could see that the patient did very well. This just 1 week after the procedure, the patient improved from 636 to 6.9 with a very small astigmatism. We published this case in JRS 2 years back. So basically the take-home message is that progressive epithelial ingrowth, fortunately it is uncommon both post-LASIK and post-smile. Post-smile it is even rarer, but it is important to note the mechanism of epithelial ingrowth. If it is post-smile, is it because of the intraoperative potential implantation versus post-operative due to the epithelial fistula, and depending on that your modality of management will change, and of course the use of circle software can be used as a novel alternative to management of epithelial ingrowth in very well selected patients. Thank you very much for your kind